Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in my lesson, I'm going to touch on the topic hemochromatosis. Hemochromatosis is the disorder that results in excessive accumulation of iron in the body. Once the iron is getting accumulated in the cells, it causes cellular death replaced by fibrosis. And there will be loss of functioning of that particular organ, resulting in multi-organ dysfunction, ultimately resulting in morbidity and mortality. This particular condition is common in hereditary hemochromatosis, a disorder that is genetically transmitted by autosomal recessive inheritance, most commonly seen in wives. Whereas secondary hemochromatosis is the result of recurrent blood transfusions in transfusion-dependent hemolytic anemias like thalassemia, sickle cell anemia, pyruvate kinase deficiency, etc. Well, this topic we are going to touch in this particular lesson with regard to its etiology, pathophysiology, clinical presentations, laboratory evaluation, and steps of management. Before we go to the topic, we look into some of the pictures here. This slide showing the normal liver in health and the liver with iron overload. Here is the patient showing hyperpigmentation of the dorsum of the hands with a little amount of deformity of the fingers due to chronic arthropathy, the manifestation of hemochromatosis. This slide shows the section of the liver in hereditary hemochromatosis showing the iron overload. Yes. This is the normal liver and its appearance in the histopathology. Well, hemochromatosis is the disorder that causes excessive deposition of iron and in turn results in multiple organ dysfunction. Okay. The organs commonly affected are the liver, heart, pancreas, thyroid, pituitary, joints, and the skin. Well, normally iron absorption is tightly regulated because there is no exit for iron from the body. There is no process that the body can eliminate the iron from the body. Yes. So its absorption is very, very tightly regulated by different mechanisms. Coming to hereditary hemochromatosis, it is the most common autosomal recessive disorder, particularly in whites. It occurs when there is pathologically high level of iron in the body. I'll come into the secondary hemochromatosis, which is seen in patients on regular blood transfusions like thalassemia, etc. Well, iron that is released in these conditions, when the iron is released from the heme part of the hemoglobin or the destroyed RBC, there is increased turnover of the RBC in chronic hemolytic anemias. Okay, and there is rapid destruction of the RBC because of the reduced lifespan. That results in the release of the heme from the hemoglobin, and the iron moiety of the heme is taken up by the macrophages and stored in the liver as ferritin. And there is what you call ferritin when it is uh, stored in excess, it is converted to hemosiderin. Okay, hemosiderin is the complex of ferritin molecules. which is stored in liver. Hemosiderin is radiopaque and ferritin is not. Hemosiderin, when it is stored in the cells, it causes cellular death replaced by fibrosis. Okay. Well, the iron that is released from the heme part of the hemoglobin is carried to the liver, whereas that released from the say that is absorbed through the intestines. Is taken to the reticuloendothelial cells. In hereditary hemochromatosis, excess iron is primarily deposited in parenchymal cells. Okay, whereas in secondary hemochromatosis, retained iron is primarily deposited in the reticuloendothelial cells. This is the difference. In hereditary hemochromatosis, excess iron, which is absorbed excessively from the intestinal epithelial cells, okay, is deposited in the parenchymal cells like liver, heart, etc. Whereas in secondary hemochromatosis, retained iron is primarily deposited in the reticuloendothelial cells. Okay, iron deposition occurs in the form of hemosiderin. So finally, it is converted to hemosiderin. Okay, that results in cellular death and ultimately replaced by fibrous tissue. Once the organ is replaced by fibrous tissue, what happens? It becomes dysfunctional. Okay, and that manifests clinically. Say there is pancreas is disturbed, there is insulinopenia, presents as the diabetes. Okay, coming to the epidemiology. Hereditary hemochromatosis is most common autosomal recessive disorder in whites. Its prevalence is around 1 in 300 to 1 in 400. It's very high. There are different types are there in hereditary hemochromatosis, that is type 1, type 2 and type 4. Type 2, 3 and 4 occurs worldwide, whereas type 1 is common in people of northeastern descent. Men are more commonly affected than women, but manifestations occurs late in women than in men. Because why? Because they lose blood through menstrual cycles. They are physiologically protected. In men, symptoms appear around fourth decade, whereas in women, they manifest around sixth decade of life. There is one more entity called juvenile hemochromatosis, wherein symptoms appear around 15 to 30 years of age. Secondary hemochromatosis is common among the people with transfusion-dependent hemolytic anemias like thalassemia and sickle cell anemia. And we commonly see the people with thalassemias. And they are transfusion-dependent. Unless you give the transfusion, they will die of anemia associated complications like congestive heart failure. If you treat them, they suffer from hemochromatosis. If they do not treat, they suffer from severe anemia and congestive heart failure. But we go by other lines of management to reduce the toxicity of the iron, like chelation therapy. There are different modalities of treatment of thalassemia syndromes, which will be dealt with in a different class. Coming to the pathophysiology. The organs affected in hemochromatosis, as I told you, are liver, pancreas, heart, thyroid, pituitary gland, gonads, skin and joints. Well, the toxicity of the iron is going to be enhanced with regard to its effect on the liver and pancreas if there is history of alcohol consumption and there is history of viral hepatitis. That is, alcoholism and viral hepatitis are going to increase the toxic effect of iron on liver and pancreas. This is very important point should be kept in mind. And cirrhosis and hepatocellular carcinoma are common. Oh, sorry for the interruption. Well, coming to the pathophysiology, iron deposited in the thyroid gland causes hypothyroidism. This is the most common cause of hypothyroidism in men. Right. As such, hypothyroidism is more common in women. In hereditary hemochromatosis, the men are more commonly affected with hypothyroidism. Iron deposited in adrenals and parathyroid gland do not show any clinical symptoms. This is the point to be remembered. Well, excess iron in the body is primarily due to massive intake of iron, oral iron, and people keep on consuming the tablets, buying across the counter, and take these iron tablets for general weakness, etc. And that may result in the excessive intake and iron excess in the body. Excessive absorption of iron in spite of normal intake because of the genetic abnormalities of the protein, that is hepcidin, okay, is associated with the increased absorption of iron in spite of normal intake. Increased production of iron due to massive blood transfusions. These are the three important factors that causes the iron overloading of the body. Well, coming to the hereditary hemochromatosis, it is because of the mutation in the gene of the hemochromatosis gene that is called HFE protein gene. The mutation in this gene is going to cause the reduced production of hepcidin and dysfunction of the transferrin receptors, okay, together leading to increased absorption of iron across the breast border of the intestinal epithelium. Okay, that results in the ultimately results in excessive abnormal or absorption of iron and iron overload getting deposited in the especially parenchymal tissues, in turn resulting in the organ dysfunction. Okay, this is what happens. Whereas in secondary hemochromatosis, this is due to massive blood transfusions. That again results in the iron overload. Okay, and in this condition, iron is deposited in reticuloendothelial organs. Coming to the clinical manifestations, they depend upon the organ that is affected. Okay, by the time you diagnose hemochromatosis, they must be suffering from non-specific symptoms. They must be suffering from the disease nearly about 10 years. Okay, and the early manifestations are severe fatigue, okay, exercise intolerance, and joint pains and hyperpigmentation of the skin. Okay, and late manifestations includes diabetes mellitus because iron deposition in the pancreas causing destruction of the pancreas, hypoinsulinemia, that results in the diabetes. And liver damage is associated with the elevated hepatic enzymes rather than presence of jaundice. There may or may not be hepatomegaly. Okay, and the presence of hepatocellular carcinoma is more common in the patients with hereditary hemochromatosis. Okay. Endocrinopathies associated with the hemochromatosis are hypothyroidism, pituitary dysfunction, present as gynecomastia, and loss of scalp hair. Sometimes they also complain of losing pubic hair. Because of the involvement of the heart, cardiac muscle, because the deposition of the iron in the myocytes, it leads to dilated cardiomyopathy and presence as congestive heart failure. Iron also gets deposited in the cells of the conductive system. That results in the erythemias and presence as congestive heart failure. When you examine, there could be third heart sound and cardiomegaly and other features of congestive heart failure. Hepatocellular carcinoma is very common in the patients with hemochromatosis. As I told you, diabetes as a result of the pancreatic dysfunction is seen in 50% of the patients with hemochromatosis, and 70% of the patients with hereditary hemochromatosis, they suffer from hepatocellular injury and cirrhosis. కష్టం ఎలాగైతే Well, sorry for the interruption. And we are talking about the clinical manifestations. And patients must be suffering from hemochromatosis nearly for 10 years before they present with the clinical symptoms. The early symptoms being the severe fatigue and joint pains and increasing pigmentation of the skin, followed by they develop features of diabetes. They develop the features of endocrinopathies like hypothyroidism, hypogonadism, presenting as the gynecomastia, and loss of hair. Well, cardiac manifestations, they present with the features of congestive heart failure secondary to dilatory cardiomyopathy, or arrhythmias secondary to the damage to the conductive system due to iron getting deposited in the cells of the conductive system that results in the dysfunction secondary to the damage of conductive system. Hepatocellular carcinoma is more common in patients with hemochromatosis who develop cirrhosis. They do suffer from recurrent infections secondary to the damage to the macrophages due to excessive accumulation of iron. Coming to the laboratory evaluation, when you suspect the individual is suffering from hemochromatosis, say that, and go ahead with the laboratory studies to see the iron status. Serum ferritin is the standard test that will tell you about the iron status in the body with respect to the total iron in the body. It's a good indicator of the iron stores, and its value more than 1000 micrograms per liter is of pathological significance. Then go ahead with the study of liver enzymes. Liver enzymes are elevated in hepatocellular damage. Okay, when there is excessive deposition of iron in the liver, which is the primary organ that is associated with the deposition of iron, and hepatic damage can be studied with evaluation of the liver enzymes, followed by MRI scan of the liver also shows the amount of iron deposited in the parenchymal cells, and liver biopsy is the gold standard to know the iron per dry weight of the liver in grams. Then cardiac MRI will reveal the deposition of iron in the liver, in the myocytes, and echocardiography changes are seen even before the onset of congestive heart failure in hemochromatosis. And X-ray or other imagings show the presence of cardiomegaly associated with congestive heart failure. And diabetic evaluation can be done with blood sugar levels, fasting, as well as postprandial. And thyroid function tests will help you to assess the presence of hypothyroidism. And hormonal levels of hypogonadism should be carried out, besides bone density studies. This is a spectrum of investigations that are carried out in a patient suspected of hemochromatosis. Then proceed with the treatment. Treatment of hereditary hemochromatosis is carried out with phlebotomies, which are beneficial in the improvement of insulin sensitivity as well as cardiac dysfunction. Phlebotomies are done at a rate of 1 to 2 times in a week initially, removing 50 to 100 ml of blood in each session. Okay, until that time you get the ferritin levels down to 50 micrograms per liter. Then subsequently phlebotomies to be continued at a rate of 3 to 4 phlebotomies in a month. Okay, that is, they are to be continued to maintain the serum levels of ferritin below 50 micrograms per liter. Okay, then if the patient is suffering from cirrhosis of the liver and there is evidence of hepatocellular failure, liver transplantation is the option. But success of liver transplantation is rather poor when compared to normal individuals. But advise avoid alcohol in order to reduce the toxic effect of iron on the liver parenchyma. Coming to the erythropoietic hemochromatosis, chelation therapy is the line of management. Okay, phlebotomies are not going to be effective. In the same way, in hereditary hemochromatosis, chelation therapy is not effective. Then follow-up advice is very important in order to evaluate the presence of hepatocellular carcinoma. Then a point about the prognosis. Untreated, the patients are progressively develop liver dysfunction, develop cirrhosis, then there is a risk of developing hepatocellular carcinoma. Okay. Early diagnosis, treated with phlebotomies, avoiding alcohol and iron containing foods, there will be decrease of most of the complications with reduction in morbidity and mortality. Though mortality will be delayed, but the suffering associated with the complications will be reduced in terms of cardiac dysfunction and insulin sensitivity. Because of the presence of advances in the diagnosis and treatment, prognosis in this hereditary hemochromatosis has improved. Well, there are two important points to be remembered. Presence of hepatitis or presence of cirrhosis, okay, at the time of diagnosis are the limiting factors with regard to improvement with treatment. So what are the complications? The risk factors for early complications are presence of hepatitis and alcoholism at the time of diagnosis. The complications being hepatocellular carcinoma, diabetes mellitus, hypogonadism, and osteoporosis. Okay. Well, this is all about the hemochromatosis. Sorry for the interruption in between. Thank you very much for patient listening, and we'll meet you again in the next class. Until that time, bye bye. I don't know. Zoom meeting is concerned.